Lyme disease is a vector-borne illness caused by the bacterium Borrelia burgdorferi. In Europe and Asia, other strains such as Borrelia afzelii and Borrelia garinii may also be involved. Transmission occurs through the bite of an infected Ixodes tick, commonly known as the deer tick or black-legged tick. These ticks must typically remain attached to the host for at least 36 to 48 hours to transmit the infection. The primary reservoirs for the bacterium are small mammals, especially white-footed mice, as well as birds. Humans are incidental hosts and do not contribute to the life cycle of the bacterium. Lyme disease progresses through 3 clinical stages. Stage 1. Early localized disease. This occurs 3 to 30 days after the tick bite. The classic feature is erythema migrans, a slowly expanding red rash with central clearing. This bullseye rash appears in up to 80% of cases. Other symptoms include fever, chills, headache, fatigue, muscle aches, and swollen lymph nodes. Stage 2. Early disseminated disease. This stage develops weeks to months after infection. Multiple erythema migrans lesions may occur, along with migratory joint pains and neurologic symptoms, such as facial palsy, meningitis, and nerve root pain. The heart may also be affected, causing Lyme carditis with arrhythmias or heart block. Stage 3. Late disseminated disease. Months to years after infection, untreated patients may develop Lyme arthritis, especially in large joints like the knees. Chronic neurologic symptoms, such as cognitive dysfunction and neuropathy, can also appear. Diagnosis is primarily clinical, especially when atypical erythema migrans rash is present in an endemic area. Laboratory confirmation is not necessary in such cases. For systemic or neurologic symptoms without a clear erythema migrans lesion, 2-tiered serologic testing is recommended. This involves an initial enzyme immunoassay, followed by a Western blot if the first test is positive or equivocal. In suspected neuroborreliosis, cerebrospinal fluid analysis may show lymphocytic pleocytosis, elevated protein, and Borrelia-specific antibodies produced within the central nervous system. For early localized Lyme disease, the first-line treatment is doxycycline. Adults receive 100 mg orally twice daily for 10 to 14 days. For children aged 8 years or older, the dose is 4.4 mg per kilogram per day, divided into 2 doses, up to a maximum of 100 mg per dose. In patients who cannot take doxycycline, such as young children or pregnant women, alternatives include amoxicillin and cefuroxime acetyl. Amoxicillin is given at 500 mg 3 times daily for adults and 50 mg per kilogram per day in children, divided into 3 doses. Cefuroxime is dosed at 500 mg twice daily for adults and 30 mg per kilogram per day in children, split into 2 doses. Both alternatives are given for 14 to 21 days. For neurologic Lyme disease, such as meningitis or cranial nerve palsy, intravenous ceftriaxone is preferred. Adults receive 2 grams once daily, and children are dosed at 50 to 75 mg per kilogram per day, up to a maximum of 2 grams. Treatment duration ranges from 14 to 28 days. Oral doxycycline may be used for isolated facial palsy without signs of meningitis. For Lyme arthritis, adults can take oral doxycycline 100 mg twice daily, or amoxicillin 500 mg 3 times daily, both for 28 days. If symptoms persist, intravenous ceftriaxone 2 grams daily is recommended for another 14 to 28 days. For Lyme carditis, particularly in patients with 2nd or 3rd degree heart block, treatment requires hospitalization and intravenous ceftriaxone 2 grams daily for 14 to 21 days. After stabilization, patients may switch to oral doxycycline to complete the treatment course. A subset of patients may experience symptoms such as fatigue, joint pain, and cognitive issues for more than 6 months following treatment. This condition is known as post-treatment Lyme disease syndrome. It is not caused by ongoing infection, and prolonged antibiotics are not recommended. Management is supportive. Non-steroidal anti-inflammatory drugs may help with joint pain. Physical therapy and psychological support can be beneficial in selected cases. Prevention of Lyme disease focuses on avoiding tick exposure. Wear long-sleeved clothing and pants when in grassy or wooded areas. Use insect repellents containing DEET on exposed skin and apply permethrin to clothing and gear. After outdoor exposure, perform full-body tick checks and shower within 2 hours. If a tick is found, remove it promptly using fine-tipped tweezers. Grasp the tick close to the skin and pull upward steadily. Clean the bite site afterward with soap and water. In high-risk cases, a single prophylactic dose of doxycycline, 200 mg in adults or 4.4 mg per kilogram in children aged 8 or older, can be administered within 72 hours of tick removal, provided certain criteria are met. These include identification of the tick as Ixodes species, attachment for at least 36 hours, initiation of prophylaxis within 72 hours, and a local tick infection rate of at least 20%. At present, there is no licensed human vaccine for Lyme disease. However, candidate vaccines, such as VLA15, are under development. And that's all for this video. If you find this video helpful, don't forget to like, share, and subscribe for more informative content. Stay tuned for our next video.